Good morning, everyone. Today I'm going to present mortality of Department of Hepatology, August 2026. This is the monthly report for July 2026. Hepatology OPD has case 8,931 cases with 967 IP admissions. LICU admissions at 181 with deaths of 48. We did UGI endoscopy of 1052 with an ERCP of 115. एंडोस्कोपिक अल्ट्रासाउंड 83 किया था एंड we have placed 2 gastric balloons. Coming to the case, uh, date of mortality, date of admission is 19/8/26. LICU death is 48. Hepatology OPD admissions are 8,931, ma'am. IP admissions are 967 with LICU admissions 181 and deaths 48, ma'am. Sorry. Coming to the last page. Patient name S, who is a 26-year-old male admitted to HDU. Index presentation, pain abdomen for 15 days, radiating to back with severe vomitings and abdominal pain. Jaundice for 3 to 4 days and breathlessness. CCT was done outside, which is showing acute necrotizing pancreatitis. During the first admission, USG guided PCD was inserted and drain fluids were sent for cultures, which are sterile. USG was done on 11/7/2026, which showed residual collection of 5.5 into 4.5 into 3.2 centimeters. Patient was discharged with IV antibiotics, and patient was discharged with OPD follow-up. But patient was readmitted on 26th of July to emergency with complaints of fever, abdominal pain for the past 3 days. On admission, vitals BP is 112/78, pulse rate, respiratory rate. Time working diagnosis is severe acute necrotizing pancreatitis with VON with a PCD placed. 28th of July, CT was reviewed. He underwent a fluoroscopic guided PCD exchange. After that, इनका like left colic artery का aneurysm हुआ है. Left colic artery aneurysm का glue and coiling was done. इसके बाद still he had drop in HB with hematochezia. Again, coiling and glue was done, following which patient developed colonic perforations. PCD से colonic contents आना शुरू हुआ. So he was taken over by surgery and he underwent bypass surgery was done for him. Colostomy was placed for him. So interventional, yes, sir, interventional radiology.
Then there was a lot of challenge in managing the situation because directly from the admission itself, they should be reported to the surgical department rather than to our department and their transfer. So this patient also long-standing chronic pancreatitis has all the complications which I wanted the surgery should have taken upfront this patient rather than the patient going like this staged, and then such patients usually don't survive at all.
He expired yesterday. He's like when I made the presentation, it is morbidity, but he expired. Coming to mortality, day of admission is 19/8/2026 and date and time of death is 24/8/2026. Case details, coming to case details, patient is a 37-year-old female. with no prior comorbids. Patient presented with complaints of fever, vomiting, and abdominal pain for 1 week, jaundice for 5 days, and altered sensorium for 3 days. Patient was admitted to outside hospital from 16th of August to 18th of August. Suspected ALF, and patient was managed conservatively there. Presented to ILBS emergency on 19th with complaints of altered sensorium. Uh, they only, yes, ma'am. Patient presented to ILBS emergency on 19th of August with complaints of altered sensorium, for which patient was intubated in ER and started on mechanical ventilation. Outside investigation showed total bilirubin of on 16 total bilirubin of 10.39 with a direct of 5.61, INR of 2.3, which increased to 3.1 on 18th of August. Creatinine, initial creatinine was 0.62, and ammonia on 18th was 464. HAV IgM and HEV IgM are negative outside. HBsAg anti-HCV are negative. Examination on arrival to ILBS ER, heart rate is 127 with BP of 116 by 65 on NORAD of 24 ml per hour and VASO of 2 ml per hour. SpO2 100% on FiO2 100% with bilateral pupils 4 mm and reactive. ONSD at the time is 4.8 mm and 4.9 mm. IVC is 8 by 10. pH is 7.53 with PO2 of 455, PCO2 of 26, bicarb of 21, but lactates at 17. Provisional diagnosis of hyperacute liver failure with indeterminate etiology. Jaundice to encephalopathy time was 2 days with MELD of 17 and KCH of 2 by 5. Current issues: patient is having hepatic encephalopathy grade 3, for which patient was intubated and on mechanical ventilation, AKI KDIGO stage 1. Shock, septic versus hypovolemic shock, persistent hyperlactatemia and persistent hyperammonemia. On admission labs, total bilirubin of 11.16 with direct of 5.8, AST of 232 and ALT of 1095. INR on arrival to ILBS is 3.40 with creatinine of 1.63. 6 lakh. Yes, ma'am. Mean arterial pressure was 80 on injection NORAD 24 ml per hour and injection VASO 2 ml per hour. Urine output on arrival to ER is only 15 ml with ammonia of 486 and INR of 3.4, lactates of 17 and IVC of 8 by 10. Initial imaging showed CT brain showed diffuse cerebral edema with a liver span of 14 centimeters. Plan was to manage shock and cerebral edema, give a transplant call and expedition of the workup, extracorporeal therapies until the transplant, and regular monitoring of prognostic markers like lactate, ammonia, and INR. This is her day one. We started around CRRT. Next slide, PM. And yes, this is day one chest X-ray. After resuscitation, her MAP became 80 on NORAD of 5 ml per hour from NORAD of 24 ml per hour and VASO 2 ml per hour. Plasmolite was given as a resuscitation fluid as per IVC. Urine output increased from 15 ml hour to 60 ml per hour. Ammonia was 493 and INR was 3.46 from 3.40. But lactates are persistently elevated from 17 to 12.8. IVC started on CRRT, ma'am. Next we went to Plex also, ma'am. Lactates of 12.8, IVC of 15 by 17, ONSD of 0.52 and 0.53. Then the FiO2 was 50%. Patient was on injection meropenem, teicoplanin, and anidolafungin. EEG was done suggestive of encephalopathy. Patient was started on CRRT at 20 ml per kg per hour in view of persistent hyperammonemia and hemodynamic instability. 4 p.m. Her MAP was 81 without any inotropic support. Urine output was 70 ml per hour. Ammonia of 6.2 and lactates of 13 with INR of more than 12. CRRT dose was increased to 30 ml per kg per hour, and patient underwent one session of low volume plasma exchange. Hepatobiliary surgery consult was taken, and at that time, no prospective donor was available, and donor identification couldn't be done. 4 p.m. patient plex was done, and after post plex, her INR is 1.85 with lactates of 5.5. Ammonia of 215 with urine output of 70 ml per hour with a MAP of 87. Etiological assessment for liver failure showed all the hepatotropic, non-hepatotropic, atypical bacterial infections, malaria, dengue, retrovirus all came to be negative. Autoimmune liver profile was negative. PCT was 2.3 with galactomannan of 0.1. Biofire multiplex PCR was negative, and blood culture, minival culture, and urine culture showed no growth. Urine routine showed RBCs of 5 to 6, WBC of 1 to 2. Coming to day 2 of admission, X-ray showed slight worsening with query nosocomial sepsis, with ONSD on day 2 is 0.57 and 0.58 with IVC of 17 by 19, MAP of 78 and ammonia of 285, INR of 1.63 and lactates of 4.7. QPI was 3 in both eyes, and pupil size was 3.12 and 3.40. CRRT was continued at 30 ml per kg per hour, but around 1 p.m. patient had sudden onset hypotension and was restarted on inotropes. FiO2 requirement was increased. Suspected nosocomial sepsis was there, and antibiotics were upgraded to injection amphotericin B and was loaded with colistin. But patient was also admitted outside hospital for 3-4 days. So that is why we are suspecting nosocomial sepsis. At 1 o'clock, her MAP was 75 on NORAD of 10 ml per hour, urine output of 80 ml per hour, ammonia is 398 with INR of 3.6, lactate of 9, ONSD at that point is 0.58.
48 hours of admission. So at day 1, why did you not make that diagnosis? Because now the patient is deteriorating. So then the nosocomial sepsis was from outside. So that is where the ALF initial antibiotics are very important. What did you give?
She was on meropenem, teicoplanin, and anidolafungin, ma'am. Initial.
To say, you should not say in ALF sepsis because inflammation itself can present like this.
Yes.
Liver failure driven shock. So we have to be very careful to say what is sepsis, what is inflammation.
Yes.
Why did what were we receiving before he came to you? And was he curating on those antibiotics or improving? That is
Patient was before initially she was on only peptides.
I want to tell you, we have not seen 6 lakh platelets in ALF. In an indeterminate, we have to look into all these things.
Yes.
Okay. In sepsis, the platelets go down in ALF.
Good.
Female, ma'am.
Nosocomial sepsis, it has to be stay for 48 hours in that particular hospital. So I just want to clarify, sir, other hospital stay is also included in the.
Would have done upfront, would have added consequence. Nothing else you could have done there. Because you did not see anything in the X-ray on day 1. Second day after post-flex, you saw some pneumonia developing there. So that was a further hit. So I think. No. Thinking that 3 days hospitalized outside, ma'am. Outside hospitalized for 3 days on single antibiotic, probably not on any antifungal. What they did was right, except that they could have added colistin or polymyxin in addition to that. Sort of that, nothing else could have been done on day one.
You have to be meropenem for the drug resistant what we see in DM. You have to provide high doses, extended infusions.
So astronab, those things have to be then considered at baseline itself. If patient has deteriorated on piperacillin. So that is one thing. Second thing is we should have done a hepatic vein Doppler, which I want to highlight again and again. In such patient, we should see a Doppler examination in a prothrombotic state.
So this was my only query from the academic point.
It is continuing, you are in the hospital, you're coming back, coming to the hospital. And you have acquired, you have an underlying infection, then that's really, that patient says that 48 hours after hospitalization. But it does not define whether hospitalization is continuous in two different hospitals. But we do presume that what we developed was what the acquired at the of hospital. If you are saying on day 2 they are suspending, then probably you must have acquired from the previous hospital.
The day he came, he had one blood sepsis.
Yes,
He
ma'am.
had several edema.
Yes, ma'am. Cerebral edema, he was started on CRRT and she was also receiving 3% NaCl also, ma'am, with CRRT. Only these two, ma'am, initially. Further, she also received mannitol, and hyperventilation strategies are also taken to control the intracranial pressure. At 1 p.m., her MAP is 75 on NORAD of 10 ml per hour with urine output of 80 ml per hour. Ammonia is 398 and INR of 3.6. Lactates of 9. ONSD at that point is 0.59 and 0.58 with QPI of 0.0. Pupil size of 6.45 and 6.12. Patient was also given additional anti-edema measures like mannitol and 3% NaCl. AK was improving, ma'am, on CRRT patient currently on. So as a because the edema is not getting controlled with CRRT after plaques, also her ONSD is high, so we have to 5.8 mm, ma'am. Day three of hospital admission showed worsening chest X-ray with ONSD of 5.8 mm and 6.0 mm, IBC of 17/20, MAP of 80 on NORAD of 6 with ammonia of 376 and INR of 4.2, lactate of 5.5 with urine output of 80 ml per hour, pupil still 6.8 and 5.8, IV CRRTs continued. Beach pe she had worsening shock. Interruptions are there, ma'am, but whenever possible, we are continuing CRRT with along with the anti-edema measures. Plex was again done on the day 3, ma'am. Day 1 and day 3 plex was done. Yes. At 4 p.m., her IVC is 18/20, MAP is 85 on NORAD of 6 with ammonia 408, INR of 4.49 with lactate of 5.4, urine output of 75 ml per hour, QPI is 0.0, pupil size of 6.5 and 5.7. Second session of low volume plasma exchange was done as salvage therapy. EEG was showing flattening of waves with diffuse slowing. 4 a.m. in the morning, her IVC is 19/21 with MAP of 75 on NORAD of 10 and VASO of 1.4, ammonia of 277 and INR of 1.67 postplex, lactate of 5.8 and urine output of 60 ml per hour, but pupil is still dilated. This is 6 a.m. ka ABG, ma'am. ABG is showing pH of 7.12 with PO2 of 74 and PCO2 of 27.5. Lactate of 15.9 with bicarb of 13.8. ONSD is 5.5 mm and 5.7 mm. With no, yes, ma'am. She is on continuous sedation. 3 ml per hour propofol is going on. Yes. MAP is fluctuating between 70 to 78 on NORAD of 40 with VASO of 2.4 and dobutamine of 5 with ammonia of 408.7, repeat INR of more than 11 and lactate of 11.2. Patient had sudden cardiac arrest at 7 o'clock in the morning and could not be revived. This is at morning X-ray at 4 o'clock. Issues: hepatic persistently high ammonia, raised ICP despite CRRT, high INR, persistent hyperlactatemia, extrahepatic refractory shock in ALF and nosocomial sepsis with ARDS. Coming to evaluation of severe shock in ALF at presentations, methods to. Yes, ma'am. Methods to assess volume status in patients with ALF and their limitations. Blood lactate, but it is a poor marker because of decreased blood lactate. Decreased blood lactate clearance. Central venous pressure has poor correlation with fluid responsiveness. Basically, what it suggests is static hemodynamic measures are not that reliable when compared to dynamic hemodynamic variables. Passive leg rising can be a dynamic hemodynamic variable which can be used, but may cause increased stimulation and may cause ICP spikes. SV stroke volume variation and pulse pressure variations could be taken up for monitoring the volume status in patients with ALF. Hemodynamic resuscitation and fluid management in ALF. Fluid depletion should be corrected immediately to prevent any potential superimposed hypoxic hepatitis, which may worsen already existing liver dysfunction. But fluid overload can also cause worsening in the intracranial hypertension and can lead to cerebral edema and herniation. Role of lactate clearance is diminished in ALF for volume resuscitation. Due to hyperdynamic circulation, SCVO2 can be normal or slightly elevated in presence of hypovolemia. And given that decreased liver function, lactate clearance can be slower and could not be a more useful marker for liver injury. Initial fluid of choice for resuscitation in ALF. Plasma has an osmolarity of 290. Normal saline is slightly hyperosmolar when compared to plasma with an osmolarity of 308. And normal saline high volume infusions can lead to hyperchloremic metabolic acidosis also. Lactated ringus has osmolarity which is lower than plasma, which is of 273. But in patients with severe liver disease who already yes.
Fluid management, and what is your one-liner for us? What do you want? What kind of fluid management?
We want to give isotonic solution for fluid resistive.
That is the second question. What do you want to create? What kind of volume?
Slide.
What should we just talk about fluid overload? Can you answer me as to what volume was your goal for ALF patient?
Slightly hypovolemic, ma'am, so that depends.
Has to be euvolemic. And first thing which has gone wrong in this patient, giving vasopressin at a IVC of 2 and 15 to it. You see in your first level, you're starting vasopressin. ALF patients have high SVRs. We did not talk about SVR, cardiac output, point of care. You just do not measure IVC. You have to do heart. You have to show lungs. Everything has to be shown. In point of care, I'll focus.
Initial IVC was. 15 by
Did not show us mixed venous. You did not talk about anything related to cardiac, hemodynamics, SVRs. Where is all that?
What is your goal?
yes, ma'am.
Among these, what is the choice of?
Uh,
Good morning, everyone. Today I'm going to present morbidity and mortality meet for the month of August 2026 by the Department of HPB Surgery and Liver Transplantation. In the month of August, we performed 14 live donor liver transplants, out of which 10 were adult and 4 were pediatric liver transplants. From Jan to August, we performed a total of 117 live donor, around 117 of liver transplants, out of which 5 were the DDLTs and 112 were live donor liver transplants. This shows the cumulative liver transplant as well as the cumulative mortality that we had in our liver transplant patients, which accounted to about 11.9% till August. The elective surgeries that were done in the month of August were around 52, out of which cholecystectomies were 23, extended cholecystectomy was 1, hepatogenostomy was around 6, incisional hernia were around 3. We also did 4 hepatectomies, out of which 3 were complex hepatectomies, which included 1 left hepatectomy in which we did hepatic artery resection as well as main portal vein resection along with the vascular reconstruction. We also did sleeve resection of pyloroduodenal junction along with sleeve resection of pancreas, which were the patient was discharged postoperatively. The second, we did a complicated hepatectomy was right hepatectomy with HDL lymphadenectomy with diaphragmatic excision and repair with right ICD insertion. The third hepatectomy was a pediatric hepatectomy for fibrolamellar ICC. We did right extended hepatectomy with HDL lymph node dissection with diaphragmatic excision and right ICD insertion. We did 4 pancreatic duodenectomies. We did a single staging lab with biopsy. We did 2 splenectomies and 4 Kasai portoenterostomy. We did a single lap cystogastrostomy and lap cholecystectomy, as well as 2 hydrid cyst deroofing. Yes, ma'am. We did 3 incision and drainage procedures and minor procedure. In emergency surgery, we did single divergent lobe ileostomy. We did an exploratory laparotomy reduction of hernia content for obstructed umbilical hernia. We did 3 tracheostomies. There was also a complicated bile duct injury. The patient had situs inversus totalis, which was referred to us, and we did exploratory laparotomy. Patient had portal vein injury. We did with the portal vein thrombosis. We did portal vein thrombectomy and portal vein repair with HJ. We also did a nephroscopic pancreatic necrosectomy. The morbidity for the month of August. The first is a 13 years old male patient who underwent live donor liver transplants for CLD sclerosing cholangitis. Patient had re-exploration for jejunal side bleed on 28th of July. He had also had abdominal wound adhesions for which we did secondary suturing on 3rd of August. Currently, patient is POD 40 and is in transplant HDO and is recovering well. He is hemodynamic stable and has stable liver functions. The second patient is 5 years old male patient who had hepatoblastoma. We did a left lateral lobe graft for him on 20th of August, 20th of July, and we had to do surgical tracheostomy for him on 4th of August due to unable to, as we were unable to wean him off from the ventilator. Patient is currently in transplant ICU and is on ventilator on 100% FiO2. Patient has fungal pneumonia as well as bacterial pneumonia, and currently antifungal and sensitive antibiotics are being provided to the patient. He also had acysto. He had he had a single episode desaturation on 25th of August, following which bronchoscopy was done and the clot was evacuated. We had a
is hepatoblastoma with portal vein thrombosis, extensive hepatoblastoma. So from pediatric hepatology side, yeah, we were not willing to subject him for transplant. So just palliative management was indicated. His disease was already spread enough. So he was almost a contraindication for transplant, and now you are managing his mucor, tracheostomy, post-transplant stay. He's EWS, but every cost is actually counted.
ma'am, patient's attendant were
All the veins, hepatic veins we have seen in our pathology class, the hepatic veins are invaded, portal vein is invaded, everything is invaded. And that was obvious before transplant also.
uh,
Transplant both on Saturdays.
At least alternative,
In the morning.
because all of us are stakeholders of our transplant patients also, patients going for transplant. What is the selection criteria? Patients with ACLF reversal are counseled for emergency transplant. So those things are very
Which of the patients should be taken up first?
first. That's what I'm saying. How are we choosing the patients? What is,
Two of my patients died in the ward, whereas this patient was called from home and
Vinay? Vinay or Nihar or anybody?
patient actually the attendants
Somebody from surgery, HPB or transplant. Sridhar is not in the loop in this patient.
This depends,
Sir.
you are going to say that this depends that attendance for the day, but this is not the.
This is not, this is not a Farmaishi program that a patient takes.
Just keep
Uh,
the decorum.
ma'am, actually we did a
Go
PET
to your
CT
next
before
patient. Nobody- he can't
taking.
You can't defend it, I can imagine that.
No. We had another morbidity. We had 74 years old male patient who had stoma retraction and midline wound dehiscence. Post the patient had a sigmoid malignancy and we did sigmoid colectomy with anastomosis. Following which there was anastomotic leak and we did then the patient had wound dehiscence and stoma retraction, for which the stoma revision was done and resuturing of the laparotomy wound was done. We had two mortalities in the liver transplant. We had four mortalities in the HPB surgery. And the first mortality is a 25 years old female patient. She came to us with the ALF, which was ATT induced, KCH 4 or 5. Patient had a left lobe LDLT on 31st of July 2026. This mortality shall be discussed in detail ahead. The second patient was 44 years old male patient. He had CLD ethanol. Patient had a MELD of 19 and had severe sarcopenia. We did right lobe LDLT on 3rd of August 2026. And patient had massive massive intracerebral hemorrhage. We did surgical tracheostomy on 8th of August. Patient died. Patient had septic shock and patient died due to septic shock. The third mortality is 54-year-old male patient. He had refractory septic shock with bilateral bacterial pneumonia. This patient had
Again, repeatedly we have said everyone dies with shock or sepsis.
yes, sir.
This is not a cause which is required or accepted.
Yes, sir.
Please don't
Patient-
write septic shock. It's not correct.
So patient had massive intracerebral bleed, following which he yes, sir. He had absent brainstem reflexes, but patient was maintaining hemodynamics, following which he had single blood culture, which was positive.
We will advise the board, they will not accept these discharges unless they're corrected.
There was another patient, he had a transplant for CLD NASH in April. Patient had a bilioma for which their EUS and guided aspiration of perihepatic bilioma was done in May and June. Patient presented to us in July with sepsis and bilateral pneumonia, for which he was admitted. He had a long course in the hospital and died, and patient had refractory septic shock with DIC with multi-organ failure due to cholangitis. There was one patient with the 26-year-old male patient who had a severe acute necrotizing pancreatitis with wall of wound. The patient had a colonic perforation post left colic artery embolization, and patient also had splenic artery embolization for massive bleed. Patient had refractory septic shock with MODS, and the immediate cause of death was refractory septic shock with MODS. Patient due to colonic perforation, which was secondary to left colic artery embolization. The patient also had splenic artery bleed. The mortality that we are going to discuss is a 25 years old female who was admitted under us on 31st of July, and she expired on 3rd of August 2026. She had hypothyroidism as comorbidity. Previously, she had undergone laparoscopic salpingectomy for ectopic pregnancy in 2024. She was incidentally diagnosed for tuberculosis on the basis of interferon gamma assays during her infertility checkups, and she was started on ATT on 10th of December. She was first noticed jaundice on 8th of July, and her ATTs were stopped. Her bilirubin on 8th of July was 12 milligram per deciliter. She was admitted in IGMS Patna, and evaluation was done, and ALF was diagnosed. Her INR at that time was 5.71, for which she was transfused 10 FFP for correction of the coagulopathy. She developed hepatic encephalopathy on 27th of July and presented to us in ER on 29th of July. She was intubated in ER due to poor GCS with HE4. The preoperative status and investigation trend. The on-admission patient had HE4 with the pupils constricted at QPI 5 and 5. She had coagulopathy with INR of 4.1. She had advanced hepatic failure with total bilirubin of 23. Her urine output was 30 ml per hour, and her creatinine levels were 0.5. She was intubated with FiO2 of 50%, and her ABG had PO2 of 217. She was maintaining MAP of 70 to 75% with NOR-ADR of 2 ml per hour. Her abdomen was soft, non-tender. These are the investigation trends of the patient. The patient had a bilirubin of 12 on 8th of July, which was gradually increasing in trend to 23 on 23rd of July. She presented to us on 29th of July, at that time her bilirubin was 23.5. Her INR was 4.13. She did not receive any plex. She had ongoing CRRT, and her INR, first there was one reading which was 3.06, following which she had another INR reading which was 5.4, and patient decision for transplant was taken. Her perioperative workup, her blood cultures and urine cultures were sterile, while miniball was not sent and KOH was not sent. The patient had PAC was done, and she was declared fit, and she was taken for surgery. Her ABG parameters were like this. She had pre-op chest X.
Pooja,
Yes, sir.
yeah, shifted in the night for ALF.
Yes.
You know about this? Go ahead.
The donor detail, her donor was husband who was 35 years old male patient. All the workup was done, and he was declared fit for donation. The preoperative problems in our patient was that she had ALF ATT induced, and she had a high oxygen requirement. We did left lobe LDLT on 31st of July for that patient. The liver during surgery, the patient had atrophic liver, which was pale and heterogeneously macronodular with rounded margins. She had a classical arterial anatomy with type A portal vein. The anastomosis was graft, LHE was anastomosed to the recipient LHE plus MHE orifice. The portal vein was anastomosed to graft LPV, from graft LPV to main portal vein. The biliary anastomosis was single duct, single anastomosis. Intra portocaval shunt was done. Patient had an inhibitic phase of 246 minutes, cold ischemia time of 34 minutes, and warm ischemia time of 47 minutes. The portocaval shunt duration was 204 minutes. She received a graft of 562 gram with GRWR of 0.7. Intra blood loss was around 700 ml. She was transferred 3 PRBC, 3 FFP, and 3 cryo with introp MPS of 250 mg. Her Doppler, introp Doppler was normal. She had this explant histopathology, which was suggestive of massive hepatic necrosis, which was compatible with ALF. In postoperative course, the patient was transferred to ICU on 31st of July 2026. Intraoperatively, temporary portocaval shunt was done and CRRT was continued intraoperatively. Intra ventilation, her oxygen saturation, her FiO2 requirement remained around 80 to 75% with PEEP of 10 millimeter mercury. She was shifted to ICU with mechanical ventilation on dual inotropic support. At low inotropic support, NOR-ADR 0.1 ml per hour and vaso of 0.1 ml per hour. Her pupils were reactive, 2 mm, and CRRT was ongoing. On POD, ma'am, but PB was ma'am, genitourinary tuberculosis. Ma'am, mostly we didn't have any.
But I remember that she started ACG only on the basis
Yes.
of symptoms
Symptoms and interferon gamma. Yes, ma'am. Ma'am, explant liver was just due of massive necrosis. Ma'am, intraoperatively, the patient looked like the liver looked like cirrhotic, but the explant histopathologist was suggestive of acute liver failure. Yes, ma'am.
She died. We don't have time. Why did she die?
Sir, she had carbapenem resistant Acinetobacter baumannii infection. Actually, unfortunately, we got the cultures after the patient died. She had,
Very rapidly. no?
yes,
What? How many days post transplant she died?
sir, she died on POD3, sir.
So she stabilized. Tell us briefly. You have a minute or two left.
Sir, on POD1, the patient was improving. Her LFTs were improving. Her PO2 was also decreased from 80 to 70%. But at around in the evening, no, ma'am,
Still nobody from transplant team is here.
ma'am, this is the trend of LFTs. From bilirubin of 23, at the admission, she had bilirubin of 5.8 on August 2nd. AST, ALT, and INR trend is also included. Yes, ma'am. No. Yes, ma'am. Ma'am, she had bilateral bacterial pneumonia, ma'am. Ma'am, it has been shown that carbapenem. Ma'am, it was sensitive, intermediate sensitive to colistin and sensitive to Iloris. But all the sensitive antibiotics were
Nobody
going.
dies like that.
If the graft is working well, the patient will not have rapid death. I'm just saying.
Yes, ma'am.
They will die still. They will not die like this.
There has to be some other cause of death, not this. All right, so what could you have done better? You had to do an ALF, you have done all the antibiotics, she received everything in the ICU. You should have looked into what is possible to improve next time. Okay, pediatrics is ready. Who is the next? No, there is a third presentation. By
Nephro.
Nephro.
Good morning, everyone. Today, I would like to present the mortality morbidity meeting by nephrology department. This is the data of the OPD and the mortality we had along with the kidney transplant in the May, June, July, which is 11, 4, and 1 respectively. The number of kidney replacement therapies we have done in the months of May, June, July. The procedures, including renal biopsy, perm cath, AV fistula in the July and June, July. Our mortality today would be about 73-year-old male, Mr. L, resident of Delhi, retired clerk by occupation. He was admitted in ILBS on 24 April 2026, admitted with complaint of fever, which is documented up to 100 degree Fahrenheit and shortness of breath for the past 2 days. Patient a case of type 2 diabetes mellitus and hypertension on oral hypoglycemic agents, metformin and telmisartan since past 12 years. In February 2020, he developed bilateral pedal edema, visited Safdarjung Hospital and was found to have a serum creatinine of 1.5. The estimated GFR at that time was 50 and urine iron was suggestive of trace albumin with sugar plus and WBCs of 4-5, but the USG was suggestive of normal sized kidneys with maintained CMD. In August 2020, he developed significant weight loss of 10 kg in the past 2 months and had sputum AFP positive. He was started on ATT for the past 6 months and patient was later lost to follow-up. Came again in the Safdarjung Hospital in straight over in March 2026, had a serum creatinine of 2 mg per deciliter at this time. On 16 April, he visited the ILBS OPD and had grade 3 bilateral pituitary edema with serum creatinine of 2.5, UPCR reports of 3.07, and was advised admission and started on diuretics, metolazine, torsemide, and SGLT2 inhibitors, and ARB. On 24, he admitted in the IPD and his fever was of low grade, not associated with any temporal variation, no chills, rigors, and no history of weight loss at that time. But he had cough with yellowish sputum, which was not blood tinged. On general examination, he had pallor, he had edema, and his temperature was 100.9 degree Fahrenheit. His respiratory rate was 26 cycles per minute, abdomen thoracic, and saturation was 86% on room air. In the systemic examination, he had bilateral basal entry decrease with fine crepes present in the infrascapular and infraaxillary area in the right side of the lung. Our provisional diagnosis at that time was acute lower respiratory tract infection, reactivation of tuberculosis, CKD G4A3 progression with volume overload, along with the comorbidity studies of diabetes and hypertension. Yes, ma'am. At that time, it was done with the first 9 drugs for 6 months. 2020, sir. Day 1 investigations, he had a hemoglobin of 7.1 and counts of about 10.73, and his creatinine at that time was 3.97. His procalcitonin was 12.7, along with the urine iron suggestive of albumin plus and sugar plus, with ESR 47 and CRP of 130. It was the X-ray on the day 1. He was admitted in Ayushman HDU because of the requirement of oxygen and was started on IV meropenem. Sputum studies were sent and HRCT chest 2D echo was done as well. This was the HRCT chest. I'm sorry, the video is not playing. This is the picture of CT, which is suggestive of fibrocavitatory nodules and septations. Sputum studies were negative for gram stain, AFP, KOH, culture, and gene expert, but HRCT chest showed bilateral pleural effusion, which was mild, with subsegmental collapse of underlying lungs, patchy areas of consolidation with fibrocavitatory lesion in the right lung. Pulmonology opinion was taken and was advised for bronchoscopy and to add IV amphotericin B. Blood and urine cultures were sterile. We also evaluated for multiple myeloma. There was no M spike. In view of increasing shortness of breath, we did a tap on the right side for 1 liter, which was transidative in nature. This was the pre-tap and the post-tap X-ray comparison. On day 2, we had an echo done. It showed severe LV systolic dysfunction of EF 3035.
Such rapid thing with CKD of pulmonary edema.
Yes, ma'am.
Rather than thinking of sepsis.
Yes, ma'am. Yes, ma'am.
The X-rays have gone rapid down. You have to think of pulmonary edema.
Okay, ma'am. In the echo further, it had severe global LV hypokinesia, and there was a mild pericardial effusion, which was 7 mm on the posterior and the lateral aspects of the heart. Cardiology reference was taken for HFrEF, and we also took an IR reference if pericardial tap could be done, but it was not amendable. His bronchoscopy was done, and BAL studies were suggestive of galactomannan, which was positive. Rest other cultures and stains were negative. His BAL galactomannan was 1.21, so he was shifted on IV voriconazole. This was the 10 of his procalcitonin. which was gradually increasing from 12.5 to 38, and ultimately in the after a few days of admission, it was 72 despite the antibiotics. Since his bilateral pedal edema,
This is very again important. If somebody's procal is rapidly rising, what are we thinking? And why the bronchoscopy is not showing any bacteria? So what is the cause of this high procal? Because fungal infection, one diagnosis where procal is normal.
yes, ma'am. Ma'am, we actually thought there could be an underlying bacterial infection going on, and that's why we thought because the PCT is rising. Ma'am, we have started on Meropenem, and then we also added ma'am, unfortunately,
We are facing this problem regularly, and we don't get for three, 4 days.
It's actually a
antibiotic.
problem because in the sepsis, first hour antibiotic has to be given. Approvals cannot be taken for patients, they will just die.
But I am told, this was a meeting where we were told that if there are sick patients, then the process is little different for patients. They are following the
Ma'am,
same.
that's
They are not giving us the empirical antibiotics.
it doesn't even come on day 4 or 5 sometimes.
50% of the cultures are sterile, procal is suppressed. How can you deny somebody and then they die because approvals are not given?
yes. Since his bilateral pedal edema was not resolving, we thought of arterial and venous Doppler, but it was having no abnormality. So we again went with the tap of right side, which is again transitative. This was the X-ray that time. Repeat IR reference was taken because now the pleural effusion was again on the right side as well as on the left side. So along with discussion with the pulmonology, IR and our primary team, we discussed for having an ICD insertion on the left side, and that was we did. Internal medicine review was taken as well and was advised to continue for IV voriconazole. Patient all of a sudden had a sudden fall in hemoglobin with no evidence of any GI bleed or any evident bleeding. His workup was sent and which was again negative. 1 unit PRBC was transfused.
About the non-invasive ventilation strategies, other supportive therapies, diuretics, means ultrafiltration, where is all that?
Ma'am,
And
we,
this looks to me like a stress-induced cardiomyopathy, Takasubo. So what was done in the cardiac echo to say that this is stress? Because it's inflammation driven.
Yes,
most
ma'am.
likely.
Ma'am, for diuretics, our patient was diuretic responsive. We had the patient on metolazine and Lasix infusion.
Patient
Ma'am,
had
insulin-
pericardial effusion also.
Yes, sir.
So what did you do for?
So for that, first we took cardiology reference and then we talked about that whether we can tap with IR as well. We took 2 times.
That could add to the reduced ejection fraction.
Yes, sir.
That has not been, and also I want to say, why do you have to do with the hemoglobin just by one? You're doing iron, ferritin, B12 for what? That's a waste.
Okay.
You know, peripheral smear can give you more than all this.
Okay, sir. Okay, sir. On 14th May, on 7:50 a.m., he had developed a sudden cardiac arrest and patient CPR was started as per ACLS protocol, but patient could not be revived. At that time, he was ongoing with ventricular tachycardia and declared deceased at 8:22 a.m. Our final diagnosis was, ma'am, he was intubated. ACLS protocol was followed, but still, yes, ma'am. Okay, ma'am.
So those pain ratios and other things have not been shown.
It was not showing patient. Secondly, I have seen this patient.
Yes, sir.
He is a non-diabetic hypertensive with nephropathy now with proteinuria. With his previous post-infection.
Yes, sir.
And appropriate antibiotic, there was some delay. I agree with that. And his cardiac function was poor because of the diabetes and other things. It's not only stress with his cardiomyopathy. So the problem was that PCT can rise in other conditions as well.
Yes, sir.
So it's not only on the basis of this that the patient died. Definitely there was delay in initiation of appropriate antibiotics. There is no doubt about that. Subsequently, it was no. He had, madam. You have to see He has bilateral lung involvement now. He has effusion. He has hypoalbuminemia.
What is the legal?
The legal standing is different, but as per Dr. Rastogi, you can upfront give antibiotic even without permission. Yeah, you can give that, and then subsequently you can seek permission. So I don't know how much was the delay.
Sir, actually, we did the same thing by giving meropenem on day one. Still, we were asked to submit the culture report suggestive that why you have given
You have to
meropenem.
proactively follow it with the administration, so they will allow you to give it.
Also,
Yeah,
ma'am, we
ma'am.
also gave the patient the option to actually shift also because he was getting sick and we were unable to manage. Yeah.
Sir, in CKD patients specifically, we have established studies that be it on dialysis or non-dialysis, 25% of patients, they have a risk of sudden cardiac death whenever they establish CKD. Because as rapidly, even the sudden, like 5 to 10 ml per minute, 1.73 meters square fall in eGFR is also correlated with increase in sudden cardiac death of about 10 to 15% as per the recent studies and guidelines.
There was some delay there, but he had a very.
Was arrhythmia documented?
Yes, sir. At the last, it was documented in the monitor.
So before the intubation, was there arrhythmia for how long?
No, sir. Before intubation, there was no arrhythmia. It was during intubation that the patient got arrhythmia.
The cause of death is arrhythmia or something else?
So that's what we still, that's.
You have something else, what you could have done better in this patient? One is antibiotic, two, anything else could have made this patient survive? Not really. Chandni, Dr. Mathur?
I,
Okay.
But again, the Procal rising is no criteria for it. Procal is only to de-escalate. It's not to say that the infection is bad.
Okay.
Let it be very clear. Yeah, this septic shock, of course, there's no doubt, but patient would not die because of that.
Chandni?
He died because of mental life.
Sir, I feel, I mean, this is also my this thing, maybe CRRT probably timely because he had very low EF and sepsis was also there. So maybe, sir, it could have maybe prolonged him or maybe helped him. So that is something which we could have done. But sir, we are facing a lot of challenge in Ayushman actually.
No,
That's-
that is the all over India,
Uh,
not ILBS. What can you do? These are government policies. You have challenges for income tax, for returns. These are challenges. We have to find our way. My only worry, this guy had pericarditis,
Okay, sir.
chronic pericarditis.
Ocular pericarditis or
And,
uremic pericarditis.
and so the
Yeah.
test
So
could be
maybe
because
amyloid, maybe amyloidosis also because he
amyloid.
had a
Did you do a
5-year
biopsy?
maybe, yeah, but with
Cardiac
this,
biopsy, postmortem.
postmortem.
Definitely, sir. We'll do that from the next time.
Okay.
And no thickening of pericarditis.
All right. Good, we have covered in time, but we need to learn more from our.
Be explained whether it was cardiac arrhythmia associated with poor LV function or with serum albumin of 1.4, it could be massive pulmonary thromboembolism also. Although he was already getting anticoagulation, apixaban, because of low serum protein.
Yes, sir. Because it came into the criteria of starting anticoagulation nephrotic syndrome patients. So he was having albumin of 1.4.
Thank you.
Thank you, sir.